Hi, we are Alex, Kaylee, and Logan, senior SRNAs here at Missouri State University, and this is our video about why quantitative neuromuscular blockade monitoring is important and why the Anesthesia Patient Safety Foundation recommends it. So first of all, why even use neuromuscular monitoring devices? Well, the Anesthesia Patient Safety Foundation strongly recommends the use of these devices if a patient is administered non-depolarizing muscle blocking drugs. This could be something like rocuronium or becuronium. And these devices are what aids in determining adequate neuromuscular recovery prior to extubation. And something important to note is that despite the use of reversal agents like neostigmine and sugammadex, residual neuromuscular blockade is something that continues to negatively impact patients. So these devices are really useful tools for us to prevent that. And continuing with the importance of neuromuscular monitoring, studies have shown that there is a 40 to 64% incidence of residual neuromuscular blockade upon patient arrival in the PACU, even after reversal with neostigmine. And this residual blockade is associated with things like impaired oxygenation and ventilation, reintubation, pneumonia, a prolonged PACU stay, decreased patient satisfaction, and ultimately increased healthcare costs. Now, just for some context, this is a quick review of the basics of neuromuscular monitoring. So a monitoring device delivers 4 electrical impulses to a peripheral nerve, and the result is a train of 4 ratio, which is the ratio of the 4th muscle amplitude response, or twitch, to the first one. And for determining adequate neuromuscular recovery prior to extubation, the accepted benchmark train of 4 ratio is greater than or equal to a 0.9. And keep in mind, a baseline ratio in an unparalyzed patient should be 1.0, and the smaller the ratio, the greater the degree of paralysis. So now to review current practice, qualitative peripheral nerve stimulators have been found to be the devices most frequently used by anesthesia professionals. These devices use a visual or tactile evaluation method to determine the train of 4 ratio, so this is going to give you a subjective measurement. And this brings us to the major pitfall of qualitative monitors. Studies show that fade of twitch amplitude cannot be reliably detected using subjective evaluation until the train of 4 ratio is less than a 0.4. So if the actual train of 4 ratio is between a 0.4 and a 0.9, harmful residual neuromuscular blockade may be going undetected.
So now we are going to talk about the Anesthesia Patient Safety Foundation specific guidelines. The first guideline is that when neuromuscular blocking drugs are administered, we recommend against clinical assessment alone to avoid residual neuromuscular blockade due to the insensitivity of the assessment. Basing reversal on how long an interval has passed since your last paralytic dose was administered is unreliable because there is a wide variation in duration of paralytic action, especially in older patient populations. Breathing pattern adequacy is also not a reliable assessment if you're using it as a clinical sign that your patient is fully reversed. Assessment of the bag on the anesthesia machine only shows that the diaphragm has been reversed. It is not telling you that the patient has adequate upper airway muscle recovery. In this situation, you might extubate a patient who is not fully recovered at a train of 4 ratio greater than 0.9. The second APSF guideline is that quantitative monitoring is recommended over qualitative assessment to avoid residual neuromuscular blockade. Qualitative monitoring is the standard train of 4 that you're probably used to seeing in the OR. One barrier cited to the use of quantitative monitors is a provider perception that these monitors are inconvenient to use and time-consuming. However, quantitative monitors take an average of 18 more seconds to apply than a qualitative monitor. In most work environments, 18 seconds of additional time does not significantly impact workflow. In a study performed to determine provider perception of difficulty of application, it was found that quantitative monitors were no more difficult to apply than qualitative monitors. The benefit of avoiding pulmonary complications alone can make this minor adjustment to workflow justified. The third guideline states that when using quantitative monitoring, it is recommended to confirm a train of 4 ratio greater than or equal to 0.9 before extubation. This is another benefit of using quantitative monitors. It is impossible to detect a train of 4 ratio greater than 0.4 with the naked eye, so using these quantitative monitors allows us to get more accurate train of 4 measurements to ensure that the patient's ratio is greater than or equal to 0.9 before extubation. Guidelines 4 and 5 go together. These recommend using the adductor pollicis muscle for neuromuscular monitoring and recommend against using eye muscles. This is because function is lost in the reverse order that it is gained in recovery. When a paralytic agent is administered, the patient will first lose the adductor pollicis muscle response, then the eye muscle response. As the patient is waking up, they are going to regain 4 twitches at the eye muscle prior to regaining all 4 twitches at the adductor pollicis muscle. This is why it's important, especially if you're using a qualitative monitor over a quantitative monitor, to use the adductor pollicis site when at all possible. Guideline 6 and 7 discuss reversal agents. Guideline 6 recommends that sugammadex is used over neostigmine at deep, moderate, and shallow depth of neuromuscular blockade that have been induced by either rocuronium or vecuronium. Neostigmine is a reasonable alternative when there is a minimal depth of neuromuscular blockade. Sugammadex is still the best choice for a deep, moderate, and shallow depth of anesthesia. Residual blockade still occurs after sugammadex. In patients who were given sugammadex, there was still a 19.2% residual blockade at 2 minutes after administration. This number did decrease to 2.8% at 6 minutes. When sugammadex is used to reverse a deep blockade, an 87% neuromuscular blockade was still present at 2 minutes. Clinical assessment skills should be utilized in conjunction with either qualitative or quantitative monitors, regardless of the reversal agent administered. The last guideline has a lower body of evidence to support it. It is recommended that to avoid a residual blockade when using atracurium or cisatracurium in conjunction with qualitative assessment, you should wait at least 10 minutes after administration of neostigmine before extubation. If using quantitative monitoring, extubation can occur as soon as a train of 4 ratio of 0.9 is achieved. Now we will discuss the different types of quantitative monitors that you might see in the operating room. The first is no longer in production, but is our baseline for comparison with other monitors. Mechanomyography, or MMG, is the historic gold standard for quantitative monitoring. It is no longer used due to a highly cumbersome setup and calibration. However, the highest level of evidence now results from comparing the newer monitors with MMG. This first type of monitoring that you may encounter is acceleromyography, or AMG. This type of quantitative monitoring is based on Newton's second law. This monitor is used by placing an electrode over the ulnar nerve with a transducer fixed to the thumb. Acceleration of the adductor pollicis muscle is going to be measured following the electrical stimulation. This monitor is subject to what's called a reverse fade phenomenon. This is where the unparalyzed baseline train of 4 reading exceeds 1. This requires the use of a process called normalization, which uses a formula of the current train of 4 ratio divided by the baseline train of 4 ratio. This allows for all of the following train of 4 ratios to be based in a context of the baseline train of 4 ratio. Recovery will be achieved when the normalized train of 4 ratio is greater than 0.9. The muscle of interest must have movement, so if the adductor pollicis muscle is used, the thumb must be able to freely move. Spontaneous movement, as in the awake patient, also affects the reliability of these readings. This monitor is currently available as both a portable monitor and integrated into the anesthesia workstation. This next monitor is kinemyography, or KMG. This monitor functions through movement of piezoelectric sensor beads, which are then translated to form an objective train of 4 measurement. The piezoelectric sensor is placed in the groove between the thumb and the index finger, as shown here in this image. The ulnar nerve is then stimulated, and the adductor pollicis muscle contractions bend the piezoelectric sensor beads. These movements are transmitted to get the actual reading. This monitor is not subject to the reverse fade phenomenon. The muscle of interest, however, must still be able to have free movement. This diminishes the monitor's value in situations where the patient positioning impacts hand movement. KMG monitors are only available as an integrated part of the anesthesia workstation. Electromyography, or EMG, is the new gold standard for quantitative neuromuscular monitoring. This has the highest level of agreement with MMG monitors and is the only monitor that does not require free movement of the thumb, allowing its use in any patient position. This works through measuring combined action potentials across the neuromuscular unit, rather than motion or a surrogate for motion, such as that of the thumb. The amplitude of the combined action potentials is directly proportional to the number of activated muscle fibers, which is what allows this information to be translated to a train-of-4 ratio. Measurement can be obtained at the adductor pollicis muscle, the first dorsal interosseous muscle, which is located at the interspace between the thumb and the index finger, and the adductor digiti minimi muscle. This offers more flexibility in where you can place your electrode patches. EMG does receive interference from electrocautery. EMG can be impacted by temperature changes. An increase in combined action potential amplitude of 2 to 3% occurs for every 1 degree Celsius decrease in skin temperature. EMG is also available as a portable or integral unit. Overall, residual neuromuscular blockade is an important patient safety issue. As anesthesia professionals, we all need to do our part to make sure that our patients are as safe as possible when we are reversing and using these agents. Quantitative monitoring with a train-of-4 ratio greater than or equal to 0.9 before extubation, accompanied by the use of antagonism with sugammadex or neostigmine, is the best practice to avoid respiratory complications postoperatively. Thank you for taking the time to watch our presentation. We would greatly appreciate it if you would fill out our pre- and post-test surveys and submit those back to us to help us out with our doctoral research.